Welcome to the Confident Nurse podcast. Today, we're taking a really full 360-degree look at traumatic brain injury, TBI. I'm excited to explore this topic today. And this isn't just about the emergency room stuff. It's a field that's really defined by some rigorous physiological management and complex ethics, too. The outcomes, well, they affect a person's entire life.
We're exploring the core curriculum of traumatic brain injury, TBI Management. Our mission at The Confident Nurse is to give you an insider's shortcut to the intensive, evidence based training frontline nurses receive. I'm Nate, here with Andrea, an ICU trauma nurse for 2 decades. We're zeroing in on practical strategies for managing severe brain injuries. This isn't theory for theory's sake, it's real world know how that turns preparation into life saving action when seconds count.
Exactly. We're pulling out those crucial evidence based frameworks, the numbers, the thresholds, the protocols, the things that really make the difference.
And importantly, the difference between reversible damage and permanent loss.
That's the crux of it. So, if you want the kind of shortcut to mastering this high stakes world of TBI care, well, this podcast should really cover it.
Okay, so our mission then is to arm you, the listener, with this essential knowledge. Let's start right at the basics. What exactly is TBI? What are we managing?
Well, TBI, it's defined pretty simply as an alteration in brain function. And that alteration is caused by an external force like a car crash.
Or a fall, possibly.
Exactly. Think severe whiplash, falls, motor vehicle collisions, assaults, things like that. And it's a huge global challenge. Massive cause of morbidity and mortality across all age groups really, but especially prominent in trauma settings.
Okay. And you mentioned something critical before we started. The most important distinction isn't how it happened, but when the damage actually occurs.
That's it. This is fundamental. We have to talk about primary versus secondary injury. It underpins everything.
Okay, lay it out for us. Primary injury first.
So the primary injury, this happens well right at the instant of impact. That moment the force hits. It includes things like immediate bruising of the brain tissue. We call those contusions. Skull fractures, obviously, or the shearing of nerve connections. That's diffuse axonal injury, or DAI.
Shearing, like tearing of the neurons in the brain.
Kind of, yeah, stretching and tearing at a microscopic level because it's direct mechanical force on the tissue. This damage is done. It's happened. And the crucial point, it is irreversible.
Irreversible. You mean to say we can't undo it? We can't turn back the clock on that initial hit? That sounds, well, pretty bleak. If that primary damage is a done deal, where's the actual fight? Where does the clinical team make a difference?
The fight happens entirely in the territory of secondary injury. This is the damage that unfolds afterwards.
Afterwards. Like, how long afterwards?
Over the minutes, the hours, even the days following the initial trauma, and it's caused by a whole cascade of other problems.
This already sounds like a major problem. What cascade of problems are we talking about?
Things like systemic hypotension, meaning low blood pressure reducing blood flow to the brain, hypoxia, which is not enough oxygen, hyperthermia or fever, and local effects inside the skull, such as cerebral edema or brain swelling.
Okay, so the brain gets hit once by the primary injury and then is vulnerable to this whole second wave of insults.
Exactly. And this is where we can intervene. The core objective, the entire mission for the critical care team, for the nurses at the bedside, it's all focused on preventing this delayed secondary cascade.
Because this secondary damage, it's often preventable.
Often, yes, not always entirely, but largely preventable, or at least mitigatable. We're fighting to save the brain tissue that was stunned or bruised by the first hit, but not yet destroyed.
Okay, I see. So, failing to prevent secondary injury means you're essentially allowing what might have been a reversible injury or a less severe injury to progress to permanent, irreversible disability or even death.
Yes, that's why understanding the environment inside the injured brain, the physiology, is just so critical.
So, to fight that secondary injury, we need to understand the battlefield inside the skull. And that brings us, I think, straight to a really core concept in neurophysiology, the Monro-Kellie Doctrine.
Yes, the Monro-Kellie Doctrine or hypothesis. It's basically physics applied to biology, really. It posits that the adult skull is essentially a rigid, bony container. It can't expand.
So, our brain is essentially a closed box.
Exactly a closed box, and inside that box, the total volume is constant. It's divided among three main things: brain tissue itself, which takes up the vast majority, maybe around 80%. Then you've got blood circulating through it, about 10%, and cerebrospinal fluid, CSF, also about 10%.
80 tissue, 10 blood, 10 CSF adds up to 100% of the volume inside that fixed box.
Precisely. So, when you have a brain injury and it causes swelling that's increased tissue volume or bleeding, increased blood volume, what happens?
Well, if the box can't expand, something's got to give.
Because the total volume cannot increase, an increase in any one of those components, brain, blood, or CSF, must be compensated for by a decrease in one or both of the others.
How does the brain manage that initially anyway?
Well, initially, the brain's actually quite clever about it. It has some compensatory mechanisms. Primarily, it shunts CSF out of the skull and down into the spinal canal. It can also compress the veins, squeezing some of the venous blood volume out.
Here, the brain pushes the fluid out like a built in pressure relief valve.
Sort of, yeah. But here's the critical part: moving from physics to clinical urgency. Those compensation mechanisms, they're finite, they're limited, they run out of room. Once the brain can't displace any more CSF or squeeze out any more venous blood, and this can happen really fast after a bad injury, then even the tiniest additional increase in volume.
Like a little more swelling.
Exactly, or even just a brief spike in blood pressure pushing more arterial blood in. Once you're past that compensatory cliff, that tiny extra bit causes a dramatic, exponential, and incredibly dangerous rise in the pressure inside the skull. The intracranial pressure, known as the ICP. That's the point of decompensation, and that path leads very quickly towards brain herniation, where parts of the brain get squeezed into places they shouldn't be.
Let's put numbers to this. What are the ICP thresholds? And at what point does a reading demand immediate action?
Right. The numbers are key. Normally, in an adult, the ICP should be somewhere between 5 and 15 millimeters of mercury. The big red flag is intracranial hypertension. We define that as a sustained ICP greater than 20 millimeters of mercury.
20, that's the magic number. That's the number the bedside nurse needs to know to start intervening.
Yes, 20 is the critical threshold. Once you're consistently above 20, you need urgent intervention, pharmacological, maybe even surgical, because the risk of ischemia, a lack of blood flow, and herniation just skyrocket.
What happens if the pressure is even higher than that?
If the ICP stays above, say, 25, you are absolutely in life threatening territory. Immediate aggressive action is needed.
20 millimeters of mercury. Burn that into memory. But you also mentioned before sometimes the trend is more worrying than one single high number.
Oh, absolutely. That's a really crucial expert insight. A brief spike, maybe it hits 22 for a minute or two during nursing care, such as suctioning the mouth or turning the patient, but then comes back down. That's concerning, but maybe manageable. What's often more alarming is watching a patient whose ICP is slowly, steadily climbing, say from 12, then it's 15, then a few hours later, it's hitting 18, then 20. That steady climb tells you the brain's compensatory reserves are failing. They're being used up. It signals that a sudden massive spike, that decompensation could be imminent. You have to act on the trend, not just wait for it to cross the absolute threshold.
Got it. Intervene while you're watching the trend rise. Now let's connect this pressure inside the skull, the ICP, to how the brain actually gets its oxygen and nutrients. That connection is cerebral perfusion pressure, right? CPP.
Exactly. CPP it's the pressure gradient that actually drives blood flow through the brain tissue. Think of it as the force available to push blood past the resistance created by that ICP.
Okay, so it's like the supply pressure minus the back pressure.
That's a great way to put it. The formula makes it simple. CPP, mean arterial pressure, MAP.
MAP minus ICP. So if your ICP goes up, say from 10 to 20, and your MAP stays the same, your CPP instantly drops by 10 points.
Instantly, which means less driving pressure to get blood into the brain.
So what's the target? What CPP do we need to keep that brain supplied?
The standard widely accepted target goal for CPP in adults with TBI is between 60 and 70 millimeters of mercury. That's the zone. If your CPP drops below 60, the risk of cerebral ischemia, the brain starving for oxygen and subsequent infarction or cell death, becomes very high very quickly.
Below 60 is dangerous, but it's not just about cranking the MAP up infinitely high to compensate, is it? I remember reading about a balancing act here. Uh,
No, absolutely not. It's a very tricky balance. While you have to maintain adequate CPP, aggressively pushing it above 70 often requires high doses of vasopressors, drugs that squeeze blood vessels to raise the MAP.
what vasopressors would be a good choice? What do you think about norepinephrine?
Norepinephrine, yeah. And the data suggests that chasing really high CPPs, say above 70 or 80, can introduce significant systemic risks.
Are you talking about risks to the rest of the body?
Exactly. You can increase the risk of things like acute respiratory distress syndrome. You can cause systemic fluid overload, put extra strain on the heart. You might actually harm other organs trying to push that CPP number higher than necessary.
Wow. Okay, so it reframes that idea of higher is always better. You're saying that 60 to 70 sweet spot is really a physiological compromise.
It really is. It's high enough, we think, to prevent widespread brain ischemia in most cases, but hopefully not so high that we're causing dangerous systemic side effects. And there's another layer too. Sometimes aggressively driving up the MAP can actually overwhelm the brain's own ability to regulate its blood flow. It's a process called cerebral autoregulation. Normally, the brain can adjust its own blood vessel diameter to maintain steady blood flow despite fluctuations in blood pressure. But after a TBI, that autoregulation is often impaired or even completely lost.
So slamming it with high pressure might just cause more harm, like more swelling, creating increased secondary injury.
Potentially, yes. It makes precise moderate control of both ICP and MAP even more critical. Hitting that 60 to 70 CPP target becomes the focus.
Okay, so we have these critical physiological numbers, ICP, CPP, often coming from invasive monitors. But the starting point and really the continuous measure of how the patient's doing is always the bedside clinical assessment. And the absolute cornerstone tool for that, known everywhere, is the Glasgow Coma Scale, the GCS.
Indispensable, absolutely indispensable. The GCS is how we standardize assessing neurological function or deterioration. It helps us classify how severe the TBI is, and it tracks three key areas or domains: eye opening, which is scored 1 to 4, verbal response scored 1 to 5, and motor response scored 1 to 6, giving a total score somewhere between 3, which is the lowest possible, basically non responses, right? Deep coma or death, and 15, which is fully awake and oriented.
Now, we probably all have a general sense of the GCS, but let's quickly review the severity classifications based on the score, and maybe more importantly, talk about the pitfalls, the things we need to be careful about when using it.
Good idea. So the classifications are pretty standard. A score of 13 to 15 is generally considered a mild TBI. Think like a concussion. 9 to 12 is classified as moderate TBI, and a score of 8 or less signifies a severe TBI.
And that GCS of 8 or less is a major decision point, right?
Huge. A GCS of 8 or less is the classic indication for intubation to protect the airway, manage ventilation, and often facilitate sedation needed for ICP control.
Okay, now the pitfalls. What makes the GCS tricky?
Well, first, it is subjective to some degree. Different examiners might score slightly differently, though training helps standardize it. More importantly, it can be easily confounded or messed up by other factors. Factors like alcohol intoxication, illicit drugs, sedating medications given in the ambulance or ER, pre existing conditions like dementia or psychiatric illness. All these can lower the score independent of the actual brain injury severity.
That makes sense. And what about the big one? The intubated patient. How do we handle the GCS then?
Yes, this is absolutely critical. When a patient is intubated, they have a tube in their throat. They cannot speak, therefore, they cannot provide a verbal response.
So the V score is unobtainable in the intubated patient.
Exactly, which is why we must document the individual subscores, the E, the V, and the M separately. We don't just write down a total number. When the verbal score can't be assessed because of the tube, we typically mark it as T. So you might see a score documented like E2M4VT. And a really common but dangerous mistake is to calculate a total score by just adding the E and M or assigning a 1 for the verbal score. That artificially lowers the perceived GCS. For an intubated patient, the motor score, M, becomes the single most important indicator of their true neurological status and trajectory.
Okay, so focus on the motor score in intubated patients. Now, if you had to pick the single most vital clinical teaching point about using the GCS in TBI assessment, what would it be?
Wow, just one. Okay, it would have to be this. Even a 1 point drop in the total GCS score, or more specifically, a 1 point drop in the motor score, that is a clinically significant event. Just 1 point. For example, if a patient was previously localizing pain, that's an M5. They reach towards a painful stimulus and now they only withdraw from pain. That's an M4. That single point drop needs immediate urgent escalation. You have to report it right away.
Why such urgency for just 1 point? Here's the nuance. It's not that one number automatically justifies a 3 a.m. phone call. No physician wants to be called because a patient is a little sleepier overnight. The urgency comes from what that number means physiologically and whether it fits a broader pattern of deterioration.
You're spot on, Nate, because waiting for a 2 or 3 point drop often means you've waited too long. The underlying cause may be bleeding, maybe swelling has progressed significantly. That 1 point drop might be your earliest warning that things are heading south, possibly past the point where intervention can easily reverse it.
Don't wait. Escalate on the 1 point drop. Okay, besides the GCS score itself, what are the other early bedside warning signs that should set off alarm bells? Things a nurse needs to spot quickly.
Well, the first and often most urgent signs involve the eyes, specifically the pupils. They're a direct window to pressure changes affecting the cranial nerves. We're looking for asymmetry, one pupil being larger than the other, or pupils that are sluggish, slow to react to a bright light, or completely non reactive. And
And what does that usually mean for the condition of the patient? When we see pupil changes, where are things headed?
a change in pupil size or reactivity, especially if it's just on one side, often signals early compression of the oculomotor nerve. That's the third cranial nerve. This nerve controls pupil constriction. Compression usually happens because of expanding pressure or a mass lesion on that side of the brain.
Unequal or sluggish pupils point to brain compression, which is why this can't be taken lightly.
It's a neurosurgical emergency until proven otherwise. A 5 alarm fire at the bedside. Absolutely.
What other signs are we looking for? What are more subtle clues that can show deterioration?
Yeah. The subtle changes are often behavioral first, things like increasing confusion. Even if the GCS number hasn't technically dropped yet, a new onset irritability or restlessness or an unexplained change in their orientation. Maybe they knew where they were an hour ago. Now they don't.
If we put this simply, it's behavioral shifts.
Exactly. And on the more physical side, keep an eye out for a new or worsening headache, especially if the patient can report it. And also new onset projectile vomiting. That's often a sign of rapidly increasing ICP.
Projectile vomiting, why is that more concerning than just regular nausea?
This typically sudden, forceful vomiting without much preceding nausea. It's the brain's reaction to that rising pressure.
Okay, those are the early warning signs. If those are missed or if the pressure just keeps climbing despite interventions, we eventually hit the really ominous late signs. And the classic one is Cushing's triad.
Ugh, Cushing's triad. Yes. If you see this, you are in deep trouble. It's the body's sort of last ditch, desperate, and ultimately failing attempt to maintain blood flow to the brainstem in the face of massive intracranial pressure. It signals imminent brainstem compression and herniation. The brain is literally being squeezed down towards the opening at the base of the skull.
And the triad consists of what key elements?
Three things. First, hypertension. The systolic blood pressure goes way up, often with a widening pulse pressure. That's the difference between the systolic and diastolic numbers. Second, bradycardia. Paradoxically, the heart rate slows down, often significantly.
High blood pressure with a low heart rate. That's one of those moments where your gut tells you something's wrong.
It is weird, and it's characteristic of this triad. The pressure on the brainstem affects autonomic control. And third, irregular respirations. Breathing becomes slow, deep, erratic, or you might see patterns like Cheney-Stokes breathing.
So, hypertension, bradycardia, irregular breathing, Cushing's triad.
If you see those three together, you are dealing with an active herniation syndrome. That patient may have only minutes before irreversible brainstem damage or death. It's an absolute crisis.
Okay, so Cushing's triad screams crisis. When we see those late signs, or maybe even just that 1 point GCS drop or a pupil change, the next step is almost always immediate imaging, right? To see what's going on inside.
Absolutely. Imaging is key.
We rely on CT and MRI scans, but you mentioned they play very different roles, especially in the acute phase.
Very different roles. Yes. The CT scan is the undisputed workhorse in acute TBI.
Why would a patient need a CT scan first?
Speed and accessibility. A CT scan is fast, usually available 24/7 in trauma centers, and you don't need the patient to be perfectly still for as long.
And why is a CT scan valuable here?
It excels at identifying the immediate life threats. It's great for seeing acute blood like epidural or subdural hematomas. It shows skull fractures very clearly. And critically, it allows us to assess for mass effect. Is there swelling or bleeding pushing the brain structures around? We look for midline shift.
Midline shift. Can you elaborate on that a little further?
Yeah, midline shift is the pressure pushing the center structures of the brain over to one side. A significant midline shift seen on CT often triggers immediate surgery. So if the patient is unstable, deteriorating rapidly, they go straight to CT.
Okay, CT for speed, blood, bone, and big bleeds. What about MRI? When does that come in?
MRI is more the specialist tool. It's reserved for when the patient is more stable or when the CT scan doesn't fully explain the clinical picture. MRI uses magnetic fields, not x rays, so it provides much better detail of the soft tissues of the brain itself.
So the MRI images reveal concerns that the CT might miss.
Definitely. It's far superior for visualizing subtle injuries like small contusions or areas of ischemic damage, little strokes caused by the trauma. And very importantly, MRI is much better at identifying diffuse axonal injury, DAI. DAI often doesn't show up well on CT, especially early on, but MRI can pick up the tiny lesions scattered throughout the white matter tracts. And DAI is often linked to the worst long term cognitive outcomes, even if the initial CT looked okay.
But MRI takes longer and is riskier in the unstable patient.
Much longer. And the patient needs to be stable enough to lie still in the scanner, often without metal implants or certain types of monitoring equipment. So, CT first for the emergency, MRI later for the detailed picture once the patient is stabilized.
Okay, let's pivot now to what we actually do, the immediate life saving interventions. When a patient with a severe brain injury hits the door, management starts with the classic trauma ABCs, but with a specific brain focused twist, right? Preventing that secondary injury.
Absolutely. Securing the basics is non negotiable, and every step is geared towards protecting that injured brain. So, airway. If the GCS is 8 or less, like we said, or if there's severe facial trauma compromising the airway, intubation is usually the first step.
Protect the airway is number one, control the breathing for the patient, number two.
Precisely, which brings us to breathing. Once intubated, or even if not, we have to be absolutely rigorous about maintaining high oxygen levels. The target is an oxygen saturation consistently above 94% and ideally an arterial oxygen level PaO2 above 100 millimeters of mercury.
Why does the care provider need strict regulation of oxygen?
Because the injured brain is incredibly sensitive to hypoxia. Even brief dips in oxygenation can drastically worsen secondary injury and outcomes. We cannot let the brain get starved of oxygen.
Okay, airway secured breathing optimized. Now, circulation. This seems like where we directly fight that brain starvation issue.
It is. Preventing hypotension, low blood pressure, is arguably the single most important systemic priority in early TBI management.
You mentioned a scary statistic earlier in regards to this.
The data is really stark. A single documented episode of hypotension, which is often defined as a systolic blood pressure, SBP, falling below 100, can literally double the patient's risk of mortality from TBI.
Double the risk from just one low blood pressure reading?
It highlights how critical perfusion is. So, the goal is to aggressively prevent and treat hypertension. We aim to keep the mean arterial pressure, MAP, up, usually targeting above 80, specifically to ensure we can achieve that vital CPP target of 60 to 70 we discussed.
How do we get the pressure up initially? Would we use fluids in this circumstance?
Initial efforts usually involve fluid resuscitation, typically with isotonic crystalloids like normal saline or lactated ringers. But we have to be careful not to fluid overload the patient either, as that can worsen cerebral edema and cause other systemic problems like ARDS. It's a careful balance.
Okay, ABCs are stabilized, maybe fluids are running. What can the nurse at the bedside start doing immediately, even before drugs, to help control that ICP, the non pharmacologic stuff?
These are foundational and they work. They seem simple, but they're incredibly powerful. First, elevate the head of the bed. The standard is 30 degrees, not flat, not straight up, but 30 degrees.
Why 30 degrees specifically?
It uses gravity to help venous blood drain out of the head via the jugular veins, reducing the volume of blood inside that fixed Monro-Kellie box, helping to lower ICP. Too high, like 90 degrees, might actually impede arterial inflow a bit. And too low doesn't help drainage. 30 seems to be the sweet spot.
Okay, head up to 30 degrees. What else is the next easy nursing step?
Second, maintain neutral neck alignment. Keep the head straight, looking forward, no twisting, no excessive flexion or extension of the neck, because any kinking or compression of those big jugular veins in the neck will immediately obstruct venous outflow from the head. It's like stepping on the drainage hose. ICP can spike dramatically just from poor neck positioning. Use towel rolls or pillows to keep the neck straight.
What about hospital room environment? How does that connect with agitation you mentioned earlier?
Yes, absolutely key. Minimize environmental stimulation and agitation. Think about it. Pain, anxiety, loud noises, bright lights, even just being moved around too much. All these things can trigger a stress response.
That stress response would raise blood pressure and heart rate, creating a new cascade of problems.
Exactly. And those systemic spikes translate directly into ICP spikes in a brain that's lost its ability to compensate. So keep the room quiet, keep the lights dim when possible. Cluster nursing care activities together to allow for periods of rest.
Grouping tasks together, can that be too taxing on the patient?
Don't be going in every 15 minutes for something different if you can avoid it. Also, aggressively treat pain and fever. Pain control is vital, and fever, hyperthermia significantly increases the brain's metabolic rate, its oxygen demand.
Fever and pain will make the brain more vulnerable to ischemia.
Precisely. So, temperature control is part of ICP management too. Use cooling blankets, acetaminophen, whatever it takes to keep the temperature normal.
I understand these non drug measures are crucial first steps. But what if, despite head elevation, neck alignment, sedation, and a calm room, that ICP number is still creeping up above 20? Then what are your next moves as a bedside nurse?
Then we move into pharmacologic interventions, and the first line is often osmotic therapy. This is our main chemical weapon against brain swelling, the cerebral edema.
Osmotic therapy. What agents are we talking about?
The two mainstays for management of ICP are mannitol and hypertonic saline.
Let's take Mannitol first. Can you elaborate on how this medication works?
Mannitol is an osmotic diuretic. When you give it intravenously, it stays in the bloodstream and increases the concentration or osmolality of the blood. This creates an osmotic gradient, meaning water naturally wants to move from an area of lower concentration inside the swollen brain cells and tissue to an area of higher concentration, the bloodstream. So, mannitol essentially pulls excess water out of the brain tissue and into the blood vessels where it can then be excreted by the kidneys.
Mannitol shrinks the brain cells a bit.
Effectively, yes. Mannitol reduces the tissue volume component of the ICP. It works relatively quickly.
Okay. And the other medication you mentioned was hypertonic saline.
Hypertonic saline works on the same osmotic principle. It's salt water that's much more concentrated than normal body fluids, typically 3% or sometimes even higher.
So, when you observe your ICP decreasing, the same mechanism is at work pulling water out of the brain.
Same osmotic pull, yes, but hypertonic saline has an additional potential benefit, especially in TBI. It also expands the plasma volume. It pulls fluid into the bloodstream, not just from the brain, but from other tissues too. This volume expansion can help raise or maintain the mean arterial pressure, MAP.
Ah, so it helps with both ICP and CPP.
Potentially, yes. By lowering ICP and supporting MAP, it can improve the cerebral perfusion pressure from both ends of the equation. That's why some centers prefer it, especially if the patient is also borderline hypotensive.
These sound like powerful drugs. What are the big risks or monitoring requirements when using these medications?
Meticulous monitoring is mandatory. For mannitol, because it's a diuretic, you can get dehydration and electrolyte imbalances, especially low potassium. There's also a risk of kidney injury if you use too much or too quickly. And if you stop it abruptly after prolonged use, you can sometimes get rebound intracranial hypertension. The pressure comes back worse.
Okay. And hypertonic saline.
With hypertonic saline, the main concern is causing hyponatremia, dangerously high sodium levels in the blood. This can have its own neurological consequences if it gets too severe or develops too quickly. It can also cause fluid overload in patients with heart failure.
So, what do nurses need to track constantly?
For both, you need frequent checks of serum electrolytes, especially sodium. You need to monitor serum osmolality regularly. There are usually target ranges. Kidney function, BUN, creatinine needs close watching, and strict monitoring of fluid intake and urine output is essential, especially with mannitol. Vital signs, obviously, and continuous ICP, CPP monitoring guide the therapy.
Intense monitoring for both sodium and mannitol. Okay, the next pharmacologic category: sedation, analgesia, and pain relief. We touched on this for minimizing stimulation, but it's also a direct ICP intervention.
It is, but this is where it gets really tricky, a balancing act, because sedation and analgesia are absolutely essential. Pain, agitation, coughing, fighting the ventilator, these all dramatically spike ICP. So we need to use drugs to prevent that. Typically, we use agents like Propofol, which is short acting, or benzodiazepines combined with potent opioids like fentanyl for pain. However, there is a downside. These drugs suppress neurological function. If you sedate someone too heavily, you can't perform an accurate neurological exam anymore. You mask the very signs you need to monitor changes in GCS, pupil responses.
This could be very dangerous. You might miss that 1 point drop in motor score because they're too sedated to respond.
Exactly. So the mantra is titrate to the absolute lowest effective dose. You want the patient calm, comfortable, not fighting the vent, synchronized with breathing treatments, but ideally still rousable enough or at least responsive enough to painful stimuli that you can track those fundamental neurological changes.
Are there specific risks with long term use of these drugs, especially propofol?
Yes, there is a specific concern with prolonged high dose propofol infusions, particularly relevant in the critical care setting for TBI patients who might need sedation for days. It's called propofol infusion syndrome, or PRIS. It's a rare but potentially fatal complication. It's characterized by a combination of severe metabolic acidosis, rhabdomyolysis, that's muscle breakdown, releasing toxins, high potassium, kidney failure, and sometimes heart failure or dangerous arrhythmias.
That sounds terrible. What causes PRIS?
The exact mechanism isn't fully understood, but it seems related to impaired mitochondrial function, especially with higher doses, typically over 4 milligrams per kilogram per hour, and longer durations, usually more than 48 hours, though it can occur earlier or at lower doses in susceptible individuals.
So, another reason for careful titration and monitoring?
Absolutely requires vigilance for early signs and regular monitoring of labs like lactate, creatine kinase, CK, triglycerides, and kidney function if a patient is on propofol for an extended period.
Okay. Moving on, seizure prophylaxis. Why the routine use of anti seizure meds after brain injury?
A seizure, even one that isn't causing obvious convulsions, a subclinical seizure represents massive uncontrolled electrical firing in the brain. This causes huge surges in metabolic demand. The brain needs way more oxygen and glucose during a seizure.
Which it might not be able to get if perfusion is already borderline.
Exactly. Seizures increase oxygen demand. They can dramatically raise ICP. They release excitatory neurotransmitters that can be toxic to already injured neurons. Basically, they accelerate secondary injury.
So we try to prevent them proactively.
Yes, early post traumatic seizures, those occurring within the first 7 days after injury, are particularly common and detrimental. Therefore, seizure prophylaxis, giving an anti seizure medication preventatively, is strongly recommended for at least the first 7 days following a significant TBI.
What drug is typically used prophylactically to prevent seizures?
The most widely used medication to prevent seizures is a medication commonly known by its brand name, Keppra. It's generally effective and has a relatively favorable side effect profile compared to older agents like phenytoin.
Okay, prophylaxis of anti seizure meds for 7 days. Finally, let's circle back to circulation. If fluids aren't enough to keep the map up and hit that CPP target of 60 to 70, we need drugs to squeeze the blood vessels. Is this where vasopressors come into play?
Correct. When fluid resuscitation alone is insufficient to maintain adequate MAP and CPP, we initiate vasopressor therapy.
And is there a preferred vasopressor choice in brain injury?
Yes, norepinephrine, brand name Levofed, is overwhelmingly considered the first line vasopressor in TBI.
Why norepinephrine specifically?
The rationale is quite specific to brain physiology. Norepinephrine is very effective at increasing systemic vascular resistance, which raises the MAP, but it seems to have relatively less direct constricting effect on the cerebral blood vessels themselves compared to some other pressors.
So it raises the systemic pressure without potentially clamping down blood flow within the brain?
That's the thinking, yes. And crucially, it appears to interfere less with cerebral autoregulation, the brain's ability to manage its own flow, than alternatives like dopamine, which used to be used more often. So, norepinephrine gives you the MAP boost you need to achieve the target CPP, hopefully with fewer negative effects within the brain itself.
The goal remains singularly focused. Hit that CPP target of 60 to 70.
That's the driving goal for vasopressor use. In this context, maintain perfusion to the brain.
Now, you mentioned advanced monitoring earlier. We talked about ICP and CPP, but you also brought up PBTO, brain tissue oxygenation. This sounds like getting even more specific information. Can you explain that?
Yes, this is definitely moving into more advanced neural monitoring, often used in specialized neuro ICUs. PBTO monitoring involves placing a very small spiralized probe directly into the brain tissue itself. Usually it's placed surgically, often at the same time an ICP monitor is placed. The ideal location is thought to be in the penumbra, the area of brain tissue surrounding the primary injury, like around a contusion. This is the tissue that's most at risk of secondary ischemic injury, the tissue we're trying to save.
And what does this probe measure? How is it valuable to bedside clinicians?
It directly measures the partial pressure of oxygen available in that specific spot of brain tissue. It gives us a localized, real time reading of tissue oxygenation.
How is that different or better than just checking the oxygen level in the arterial blood from an ABG?
It's fundamentally different. Your systemic PO2 tells you how much oxygen is available in the blood being delivered to the brain, but it doesn't tell you if that oxygen is actually reaching the brain tissue effectively, especially in injured areas.
Why might oxygen not reach the brain tissue?
You could have localized swelling compressing tiny blood vessels. You could have vasospasm clamping down arteries in one area. You could have increased metabolic demand in that specific region, using up oxygen faster than it's delivered. So you might have a perfectly normal systemic PaO2 of, say, 120, but the PBTO reading in the at risk brain tissue could be dangerously low.
What's considered dangerously low for a PBTO reading?
The generally accepted critical threshold is less than 20. Some sources even use 15. A PBTO reading consistently below this level signals significant localized cerebral hypoxia or ischemia, even if other systemic parameters look okay.
And when you see that low PBTO reading, what does it prompt you to do? How does it change management?
It becomes a direct target for therapy. If the PBTO is low, it might prompt us to be more aggressive in optimizing the patient's systemic oxygenation, maybe aiming for a higher PaO2 than usual, sometimes called therapeutic hyperoxia, or it might push us to increase the CPP target slightly, trying to drive more blood flow to that struggling area. It can also trigger investigations for things like vasospasm. It gives us a direct physiological signal from the tissue we're most worried about.
That really drives home the complexity. You're managing the whole system, MAP, SPO2, while also monitoring and reacting to these very localized conditions inside the brain, the ICP and PBTO.
Exactly. It's multimodal monitoring. So, the key advanced monitoring red flags that demand immediate attention and usually a coordinated response are a sustained ICP of 20, a CPP of 60, and now we add a PBTO 20. Seeing any one of these, or especially a combination, means the brain is in trouble and needs help urgently.
Okay, we've covered the intensive medical management, but sometimes, despite all those efforts, the positioning, the osmosis, the sedation, the pressors, the ICP stays stubbornly high above 20, or there's an acute bleed that's rapidly worsening the patient's condition. That's when we have to consider surgery.
Yes. When maximal medical management fails or isn't appropriate because there's a distinct surgical lesion, then neurosurgery becomes the next step.
What are the main types of surgical interventions we see in severe TBI?
Broadly, there are two main categories. First is hematoma evacuation.
So, this would be removing a blood clot.
Exactly. This is done for significant epidural hematomas or subdural hematomas, bleeds occurring between the skull and the brain or within the brain's coverings. Surgery is usually indicated if the hematoma is large, causing significant mass effect or a midline shift.
That midline shift you mentioned, often seen on CT scan. Can you explain the significance of that?
A midline shift greater than 5 millimeters is a common indication for surgery, or if the hematoma is expanding rapidly or causing acute neurological deterioration, like a blown pupil. The goal is simply to remove the clot, relieve the pressure, and stop any active bleeding.
Okay, evacuation for bleeds. What's the second main type of surgery?
The second major intervention is a decompressive craniectomy. This is reserved for cases of refractory intracranial hypertension, meaning the ICP remains dangerously high, persistently 20/25, despite all the medical therapies we've discussed. In this procedure, the neurosurgeon removes a large piece of the skull bone, creating a window. Temporarily, they remove the bone flap, store it usually, often in a freezer or sometimes in the patient's abdominal wall. And then they often open the dura, the tough covering over the brain. This allows the swollen, injured brain to swell outward through the opening in the skull instead of swelling inward and downward, crushing the vital brain stem structures.
Wow, that's intense. You're literally removing part of someone's skull to save their life. You're giving the brain space to survive when everything else has failed. This isn't tweaking meds or adjusting a vent setting. This is crossing a line into last ditch territory. You're saying, we've exhausted every option, and now we're physically opening the body to relieve pressure that would otherwise kill them. Because at this point, medicine is doing everything it can just to keep the door open.
It is generally considered a rescue therapy when medical management has failed to control life threatening ICP. It can be life saving, but it's a major operation with its own set of risks and implications.
What are the big risks right after a craniectomy?
Well, immediately post op, there's still the risk of ongoing swelling, bleeding, or infection, especially since the brain is less protected. There's also a risk of herniation outward through the defect, sometimes called external herniation. And later, patients who've had a decompressive craniectomy are at higher risk for developing hydrocephalus, a buildup of CSF requiring a shunt.
And what happens to the missing piece of skull?
Once the brain's swelling has subsided significantly, which can take weeks or months, the patient will typically undergo a second surgery called a cranioplasty, where the original bone flap or custom synthetic implant is put back in place to restore the skull's integrity.
Okay, and before that cranioplasty, while the bone flap is out, are there specific issues? I think I read about something called syndrome of the trephine.
Yes, this is also known as sinking skin flap syndrome. It's a phenomenon that can occur in patients with large skull defects. The atmospheric pressure pushing on the unsupported scalp and brain can apparently lead to subtle changes in CSF dynamics and cerebral blood flow. Patients might experience symptoms like headaches, dizziness, fatigue, mood changes, or even neurological worsening, which often improve dramatically after the cranioplasty restores the normal closed cranial vault.
Fascinating. So, after these major surgeries, evacuation or craniectomy, what's the immediate post op nursing vigilance focused on?
It's intense. If there's a drain placed during surgery, like an external ventricular drain, EVD, or a subdural drain, monitoring the output is critical. A sudden large increase in bloody output could signal a postoperative rebleed, which is an emergency requiring immediate notification of the surgical team. Then continue the tight ICP and CPP monitoring, of course. Even if a clot was removed or the skull opened, swelling can still occur or reoccur. Frequent neurological checks are vital, or GCS pupils watching for any deterioration. Monitor the surgical incision for signs of infection, redness, drainage, warmth, and manage pain and sedation carefully, just like before.
Okay, so assuming the patient survives the acute phase, survives the surgeries, they then face what sounds like a very long and challenging road. Let's take a look into rehabilitation and long term outcomes.
It's absolutely a marathon, not a sprint. Recovery from moderate to severe TBI unfolds over phases. You start in the acute phase, which is really about medical stabilization in the ICU and acute care hospital. Early mobilization might start here if possible. Then patients typically transition to the subacute phase. This often involves intensive inpatient rehabilitation, usually in a specialized rehab facility or unit. Focus here is on regaining basic functions, mobility, self care.
Acute, then subacute rehab. Then what? Does the patient go home?
Then comes the post acute phase. This might involve structured outpatient therapies, day programs, or community based rehab. The focus shifts more towards higher level cognitive skills, community reintegration, maybe vocational retraining. And finally, there's the long term phase, which is really about lifelong adaptation, managing persistent deficits, accessing ongoing support, and maximizing quality of life in the community.
And the deficits people face long term, they're complex, aren't they? It's not just about walking or talking again.
Not at all. While motor impairments like weakness or spasticity are common and visible, the cognitive and behavioral consequences are often the most pervasive and disabling in the long run.
Cognitive impairment seems like the really big hidden burden of TBI, where a patient can physically appear 100% recovered, however, the brain has not.
It absolutely is. Damage, particularly to the frontal and temporal lobes, which are commonly affected in TBI, leads to a wide range of cognitive deficits. We see persistent problems with attention and concentration, processing speed, how quickly they can think or recall memory, especially learning new information.
And you mentioned executive functions earlier. That sounds critical for everyday life.
It's arguably the most impactful. Executive functions are those high level skills managed by the frontal lobes. They include things like planning, organizing, sequencing tasks, problem solving, impulse control, self monitoring, and flexible thinking.
What does poor executive function look like in real life?
It means the survivor might struggle immensely with tasks that require multiple steps or forward thinking. They might know what they want or need to do, but they can't figure out how to start or how to break it down into manageable steps. They might get easily distracted, act impulsively without thinking of consequences, or have trouble adapting when plans change. This makes things like managing finances, holding down a complex job, even driving safely extremely challenging.
That sounds incredibly difficult to live with. And closely tied to these cognitive issues are often emotional and behavioral changes, too.
Very closely tied, yes. The neurological injury itself, combined with the immense stress and life changes following TBI, leads to a high prevalence of emotional and behavioral issues. Clinical depression and anxiety disorders are extremely common among TBI survivors. We also frequently see increased irritability, agitation, emotional lability, meaning rapid, intense mood swings that might seem disproportionate to the situation, and sometimes personality changes or disinhibition.
That must put a huge strain on families and relationships.
Massive strain. These behavioral changes can be very difficult for loved ones to understand and cope with. It often requires intensive psychological support and counseling, not just for the survivor, but for the entire family system.
So, given this long, complex recovery trajectory with physical, cognitive, and emotional challenges, how does the nurse's role evolve as the patient moves through these phases?
The role shifts significantly from the acute life saving focus. In rehab and long term care, the nurse becomes much more of a care coordinator, an educator, a preventer of secondary complications, and a powerful advocate.
What kind of secondary complications are we talking about later on?
Secondary complications can be related to immobility or neurological deficits preventing pressure injuries, bed sores, deep vein thrombosis or blood clots, contractures, managing bowel and bladder issues, or preventing falls.
And this is where education and advocacy quietly become just as important as any medical intervention.
Intense patient and family education is key, helping them understand the deficits, teaching compensatory strategies, explaining medications, navigating the healthcare system. And advocacy is huge, connecting patients and families with necessary resources like support groups, vocational rehab services, long term therapy, specialized housing if needed, advocating for their needs within the healthcare system and the community.
It sounds like a vital, ongoing role. Now, finally, we have to touch on the really difficult area of legal and ethical dilemmas. TBI, especially severe TBI, throws up some major challenges here, starting with the decision making capacity.
Yes, this is a huge area. When a TBI patient has impaired consciousness or significant cognitive deficits affecting their understanding, reasoning, or communication, the fundamental issue of informed consent becomes incredibly complex.
Because they may not have the capacity to understand what's happening to them, weigh risks and benefits, or communicate their wishes clearly. Suddenly, decisions that should belong to the patient now belong to families and care teams. Then consent, as I imagine, becomes layered and heavy, shaped by fear, urgency, and incomplete information. This must force everyone involved to slow down, ask harder questions, and protect the patient's dignity.
Exactly. Capacity isn't an all or nothing thing. It's functional, it can fluctuate, and it's specific to the decision at hand. But many moderate to severe TBI survivors will lack the capacity, at least initially, to make complex choices about treatments, procedures, or even discharge planning.
So, who makes the decisions then?
Decision making usually falls to legally recognized surrogate decision makers. The hierarchy for this is typically determined by state law, usually starting with the spouse, then adult children, parents, siblings, etc., unless the patient has previously designated a healthcare power of attorney or has a clear advance directive like a living will outlining their wishes.
What's the nurse's role in navigating that?
The nurse plays a critical role in ensuring that the surrogate decision makers receive clear, understandable, unbiased information about the patient's condition, prognosis, and the risks and benefits of different treatment options. We need to support them in making decisions that align with the patient's previously expressed values, or if those aren't known, what's believed to be in the patient's best interest.
That sounds challenging, especially when the prognosis is uncertain or the family disagrees.
That's where conflict and moral distress often arise. These are incredibly common in difficult situations in TBI care. You might have disagreements between family members about the goals of care, or the family might be pushing for aggressive, life sustaining treatments, ventilators, feeding tubes, ongoing surgeries, when the medical team feels the prognosis for meaningful recovery is extremely poor, leading to potential futility arguments.
Balancing aggressive treatment versus quality of life appears to be one of the hardest parts of caring for someone with a traumatic brain injury. On one side, you have every possible intervention: more machines, more procedures, more time in the ICU. On the other, you have the reality of what survival might look like. Will they wake up? Will they recognize their family? Will they ever walk, speak, or live independently again?
Exactly. Or conversely, sometimes families might want to withdraw life support sooner than the team feels is appropriate, especially if recovery potential is still unclear. These situations are ethically fraught and emotionally draining for everyone involved, including the healthcare team.
What's the mechanism for resolving these conflicts?
Involving the hospital's ethics committee is absolutely essential in these cases. They provide a structured, neutral forum to discuss the ethical principles involved: autonomy, beneficence, non maleficence, justice. Review the medical facts, understand the family's values and concerns, and help mediate a resolution that respects the patient's dignity and rights. It's not about taking sides, it's about facilitating an ethically sound decision making process.
Okay. And on the purely legal side, are there specific protections or responsibilities nurses need to be aware of with TBI patients?
Yes. First, nurses need to be aware of patient rights under federal laws, like the Americans with Disabilities Act, ADA. TBI survivors with lasting deficits qualify as having disabilities, and the ADA guarantees them certain rights regarding access to care, reasonable accommodations, and non discrimination.
Other than ADA protections, which are very valuable for the patients, what other protections are in place?
Critically, TBI survivors, especially those with cognitive or communication impairments, can be very vulnerable. They might be dependent on others for care. Because of this vulnerability, nurses are mandated reporters, meaning if a nurse has reasonable suspicion of abuse, physical, emotional, financial, neglect, or exploitation of a vulnerable TBI patient, they have a legal obligation to report those concerns to the appropriate adult protective services agency. This is a crucial safety net.
Wow, we have really gone from the cellular level to the physics of the Kelly-Monroe Doctrine all the way through ICU interventions, surgery, the long haul of rehab, and into the really complex landscape of legal and ethical TBI recovery. It's a field that demands high level vigilance, but if we distill it down, that essential framework we talked about holds true.
You need the foundation's understanding that primary injury is done, but secondary injury is the preventable target. You need the core physiology knowing that ICP above 20 is dangerous and that CPP needs to be kept in that 60 to 70 range. Remember, GCS subscores matter. A 1 point drop is concerning and a pupil change is an emergency.
And I would say mastering the interventions, the ABCs for the brain, knowing how and when to use osmotic therapy like mannitol or hypertonic saline, understanding why norepinephrine is the go-to pressor, and recognizing when surgery might be needed. And I think understanding those critical thresholds and the why behind the interventions is what really empowers the bedside nurse. This will help you advocate and give truly high quality care. And the evidence consistently shows the single most powerful factor in improving TBI outcomes is often that informed, diligent person, right there at the bedside, noticing the subtle changes.
We started by saying the primary injury, the initial hit, is irreversible. We are always playing catch up from that moment, always fighting the secondary cascade. So, maybe a final thought for our listeners today to chew on as we wrap up. If we accept that the severity of long term disability after traumatic brain injury is hugely influenced by how well we prevent or mitigate that secondary injury, what does that say about our responsibility?
That's an intriguing thought. What is the collective moral cost or even the social cost when we fail to consistently implement the simple, timely interventions that we know can prevent so much of the secondary damage? Things like rapidly correcting hypotension or hypoxia in the trauma bay, or the ICU interventions that are largely in our control. It really places the burden squarely on having prepared systems, diligent providers, and robust protocols. It emphasizes that preventing the preventable is possibly the most critical intervention of them all.
Nate, that sums it up. We encourage you to continue your curiosity in your own understanding of health for yourself daily in your nursing practice and advocate for systems that prioritize rapid, informed, and truly compassionate care. Thanks for joining us today on the Confident Nurse podcast.
Don't let license renewal sneak up on you. Get your accredited CE courses, printable study guides, and quick quizzes to lock it in. Download certificates instantly, finish your hours, feel confident, and get back to life. ConfidentNurse.com